Hello everyone and welcome to my channel and another video in our clinical pharmacy course. In today's video I bring to you a new clinical pharmacy case that we're gonna solve together, and I'm gonna ask you to solve it on your own as usual to see if you're gonna get the correct answer or not. It's okay to get it wrong. We're practicing together on this channel. And then we're going to go through the case together in this video, and I'm going to show you how to solve such cases with ease in the future. Now, practice will make you an excellent clinical pharmacist. Now, for those of you who are new on the channel, this channel is all about clinical pharmacy practice. If you want to become a clinical pharmacist, if you want to advance your career, this channel is all about that. Make sure to subscribe to the channel and activate the bell so that you get notified of my future videos, and make sure to watch the other videos I have on the channel. They're all for free. Now let's get started with today's presentation, and as usual we have a case, and this is a 50-year-old female who presented to the emergency department with complaints of progressive abdominal pain and melena for the last week. She also complained of increased weakness. The patient noted that she had abdominal pain that started 2 weeks ago, and her GP gave her a course of Flagyl that helped a little bit. Now, for those of you who don't know what Flagyl is, that's metronidazole. It's an antibiotic. Patient was sent immediately for a colonoscopy, which revealed a duodenal ulcer. An H. pylori test was done, which came back positive. So she's positive for H. pylori. The patient does not have any past medical history and does not use any medications at home. She has a documented allergy to penicillin. The doctor would like to start her on H. pylori treatment, and he prescribed clarithromycin 500 milligrams twice a day, pantoprazole 40 milligrams twice a day, and amoxicillin 1 gram twice a day for 5 days. Now, this is a typical regimen for H. pylori. If you're not aware of that regimen, I would suggest Google H. pylori treatments and look at the literature, or if you have a reference that is infectious diseases related or has information about H. pylori, just look at the basic information on H. pylori treatment. You'll find that the first line therapy is to combine clarithromycin with a PPI, a proton pump inhibitor like pantoprazole, and amoxicillin. So the doctor prescribed the typical first line therapy for this patient for her H. pylori. You are the pharmacist on the unit, and the doctor asks you to check the prescription doses for appropriateness before discharging the patient. This is a typical question. The doctor will call you, hey, Joe, can you check the prescription before I send the patient home? Just so that you're more aware of the medications and their doses, and he will have another set of eyes on the prescription before sending the patient home with the wrong dose of the medication. Describe the pharmacy interventions needed in this case. Now let's say that the prescription was written appropriately. Everything is appropriate. The doctor left his name and license number and signed on the prescription, so every legal part of the prescription is appropriate and is there. You only have to review the prescription medications for dosing appropriateness to make sure that this is the right drug for the right patient at the right dose with the right route and all that stuff. So the 5 R's, if you remember, we talked about them in previous videos. You have to check if everything is prescribed appropriately. Now, as I tell you in all my videos, at this point you have to pause the video and try to solve the case. See if you need any interventions as the clinical pharmacist on the unit. Now, you are the clinical pharmacist on the unit, and you have this case in front of you. Write down your interventions. What would you do in such a case? Go through the information available. You don't have a lot of information here. This is all you have. And most of the time, you're not going to have a lot of information, and you're not going to have a lot of time to review a patient's case. So just pause the video at this point, solve the case, and come back. I'm going to go ahead and continue with the video when you come back. Moving on to the next slide. So a brief introduction about H. pylori. Helicobacter pylori is a common bacteria infecting about half of the world's population. H. pylori is associated with the development of gastrointestinal disorders such as chronic gastritis, peptic ulcer disease, and gastric adenocarcinoma even. H. pylori is also involved in the development of other extragastric disorders, such as a mucosa-associated lymphoid tissue lymphoma, which is called MALT, idiopathic thrombocytopenic purpura, vitamin B12 deficiency, and iron deficiency. So it is something that we have to take into consideration, and we have to treat as soon as we catch it, because it can cause a lot of harm, as you can see. H. pylori treatment and resistance patterns. Like any other bacteria, H. pylori has developed some resistance to some antibiotics and continue to develop resistance. The recommended treatment for H. pylori eradication is the standard triple therapy using a PPI plus clarithromycin plus amoxicillin or metronidazole. So you can use either amoxicillin or metronidazole plus clarithromycin plus a PPI of your choice, whatever you have in your country. It could be pantoprazole, omeprazole, esomeprazole, whatever you have, and use the standard dose, which is usually twice a day. So for example, if it's pantoprazole, it's 40 milligrams twice a day. Same thing with esomeprazole. The increase in the prevalence of resistance to these antibiotics, especially to the key antibiotic, which is clarithromycin, has decreased the efficacy of standard regimens. Now, in some parts of the world, there is more than 25% or 50% even resistance to clarithromycin, and that's why we should not use that regimen which contains clarithromycin in those patients with H. pylori infections in those parts of the world, because if there is a resistance to one of the antibiotics that you're using for H. pylori, then the treatment is not going to work, and the H. pylori is not going to be eradicated. So you should choose the right regimen. The prevalence of metronidazole resistance has been estimated to be anywhere between 17 and 44% in Europe and America only. So you can imagine that there is a high level of resistance to metronidazole in some parts of the world as well. So imagine if a patient lives in a part of Europe or America where there is resistance to clarithromycin and to metronidazole, that means this whole regimen is not going to work. However, it's still the first-line regimen for H. pylori because it's cheap, it's easy to use, there are less interactions with other medications. Probably not with the clarithromycin, though. There is a lot of interactions with clarithromycin, but less side effects maybe, and its availability is really available for everyone. Other H. pylori treatments available are the bismuth quadruple therapy. Now, this therapy contains two antibiotics, which are the tetracycline and metronidazole, plus bismuth plus a PPI, and it's usually for 14 days. The therapy is preferred as a first-line treatment nowadays for areas with high incidence of clarithromycin resistance, and also as a second-line therapy when the first-line treatment with the classical triple therapy against H. pylori fails. The classic triple therapy is what we've been talking about since the beginning of this video, which is the clarithromycin plus amoxicillin plus PPI. Another treatment option is the sequential therapy, and this type of therapy uses the same antibiotics as the standard triple therapy. However, they are given in a sequential way, so 5 days of a PPI plus amoxicillin, And then after that, you do another 5 days of PPI plus clarithromycin and amoxicillin. So that's why it's called the sequential therapy. It is also another therapy that has been documented in the literature. It showed some benefit over the typical triple therapy. So it is another method that you can use for H. pylori treatment. Another way of treating H. pylori is by using the levofloxacin-based therapies. And again, due to the increased clarithromycin resistance, levofloxacin is another broad-spectrum antibiotic. It's a fluoroquinolone that can be used for H. pylori eradication in order to substitute clarithromycin in triple or sequential regimens. So basically, any regimen with clarithromycin, just remove the clarithromycin and put levofloxacin, and it should work. And that's another treatment that has been documented in the literature. Now, bear in mind that maybe those treatments are not approved by the FDA in America or North America. It might be not approved where you live as well. However, they are documented in the literature, and we do use them, and we have seen success with any of these treatments. Now, the initial approach to antibiotic treatment in H. pylori should follow as this algorithm in front of you. Basically, a patient comes in, we test them for H. pylori. That test comes back with a positive result, and then we look at the following. Did they have any exposure to macrolides for any reason? Could be for a respiratory infection or for any other infection. Or is there any clarithromycin resistance that is more than 15% or 15% or more in the area that we live? Or if the eradication rates with clarithromycin triple therapy are less or equal to 85%. If that's the case, if it's a yes, then you immediately don't prescribe a triple therapy. You go immediately to the bismuth quadruple therapy. However, if that's not the case, the patient didn't get a macrolide recently, there is no high resistance rates to clarithromycin, then look at the penicillin allergy. If the patient is allergic to penicillin, then you can switch to flagyl instead of penicillin and use the triple therapy. However, if the patient is allergic to penicillin, if the patient is allergic to penicillin, you have to look at whether or not the patient used metronidazole within the last few years. If that's the case, if the patient did use metronidazole in the last few years, then you start bismuth quadruple therapy again. If the patient did not use metronidazole, then you can treat with the triple therapy. Just substitute the amoxicillin part with metronidazole. Now, let's say the patient does not have a penicillin allergy, then you can simply use the triple therapy, which is clarithromycin, amoxicillin, and PPI. So it's that simple. It's not complicated. If you read through this algorithm, you should be able to determine which therapy is to use. Of course, this algorithm does not have the levofloxacin therapy, for example, or the sequential therapy. You can use those ones as well. If you don't want to go with the bismuth quadruple therapy, let's say you don't have the bismuth component, which is a subsalicylate that we use. You don't have that available in your country, so you're not going to use this therapy for sure because you don't have one of the components. If you don't have one of the 4 components of the therapy, then it doesn't make any sense, right? You can do the levofloxacin based therapy or the sequential therapy. Again, bear in mind that metronidazole use or recent use can be problematic because the patient might have some resistance to metronidazole. So if that's not the case, you can always use metronidazole without any hesitation. The bismuth quadruple therapy regimen basically includes a PPI at the standard dose, which is usually twice a day. For example, pantoprazole twice a day. It has either bismuth subcitrate or you can use bismuth subsalicylate, whichever is available. Like in North America, we do have the subsalicylate. and the dose even is flexible, anywhere between 300 milligrams or 524 milligrams. I believe in Canada we do have the 524 milligram bismuth subsalicylate. We don't have the 300 milligram. So whatever you have, and that one should be given 4 times a day. So whether it's 300 or 524 milligrams, give it 4 times a day. There's also 420 milligrams here I see from the citrate, 120 or 300 milligrams. All of these are not available in the US, but there could be different concentrations in different countries. The third component is the tetracycline, and we use 500 milligrams of that 4 times a day. Now remember, tetracycline is a medication that the dose needs to be adjusted for kidney failure. And if that's the case, if your patient has CKD or acute kidney injury, you need to adjust this dose based on their kidney function. Just because the recommended dose is 500 milligrams 4 times a day doesn't mean that you have to do that. That needs to be adjusted based on the current kidney function. If the patient kidney function requires twice a day dosing, just switch to twice a day dosing and give 500 milligrams still, but every 12 hours. Finally, the final component is metronidazole, and it's either 250 or 500 milligrams. You can do 250 4 times a day, or you can do 500 milligrams 3 to 4 times a day. Both of them have been documented in the literature. Both of them have shown success rates. So either one of them, whichever is more convenient to the patient, go with that. And don't forget that the duration of treatment should be anywhere between 10 and 14 days. Right, moving on to the next slide, and the final slide actually. Back to our case for today. So our patient had a positive test for H. pylori, and they also had a duodenal ulcer. So they are a high risk. They need to be treated right away. We don't have any data on the clarithromycin resistance. They didn't say anything in the case. The patient was not exposed to macrolides, so they didn't tell us anything about any macrolide course. But the patient had a documented allergy to penicillin. That was documented in the case. That means we can't use amoxicillin in this patient. And the patient used metronidazole a couple of weeks ago. Let's go back to the case and see all that information. So it says here she has a documented allergy to penicillin right here. And up there, she had an abdominal pain 2 weeks ago, and her GP gave her a course of Flagyl. So 2 weeks ago, Flagyl, which helped her. So she did take Flagyl 2 weeks ago. So let's go back to the algorithm here. So that one we don't know. We're going to say no. Penicillin allergy, yes. We're going to go with a yes. Flagyl use within the past few years, actually within the past 2 weeks, so yes. So this tells us we have to go with the bismuth quadruple therapy. So for this patient, the correct answer or the correct intervention is to switch her triple therapy to a bismuth quadruple therapy. And in this case, you would call the doctor or meet with the doctor, however it's more convenient to the both of you, and tell them about your concerns, because the doctor probably doesn't know about all these things that you found out. Tell them about your concerns and give them your recommendations. So your recommendation would be to switch from this triple therapy to a quadruple therapy because of these concerns that you had, you noticed. The penicillin allergy, the recent use of Flagyl, so we can't switch amoxicillin to Flagyl and use the triple therapy. And also, because she used Flagyl, we have to switch to the quadruple therapy. And the doctor usually would say, yes, sure, go ahead, and prescribe that on my behalf. There's one more problem here. The 5 days duration, that's not appropriate. That's not enough for the eradication of H. pylori. So you would tell them that we need to do that for 10 to 14 days of the quadruple therapy. Even if we would have gone with the triple therapy, Let's say there's no issues at all, and no intervention is needed. The only intervention would be is to change the 5 days to either 10 or 14 days of the triple therapy, whatever is the guideline in your country recommends. Most literature recommends 10 to 14 days, so I don't think it would be different where you live. So that would be another intervention here. Make sure to give the right duration of therapy so that you're sure that the H. pylori is eradicated. That's all for today's case. I hope you all got it correctly. I'm preparing a few other cases in the next few days, so those will be published as soon as they're ready. Let me know in the comments if you got the answer correctly, and I'll see you in the next presentation. Thanks for watching, and have a great day.